Great. Now it's my chance to try and show I was paying attention to everything they said. And so I want to start with leading off for one question with possible follow-ups to each of the speakers. And then I have some more notes, just as I noticed many of you writing down your questions as this was going. So I invite you to think of a question you'd like to ask, and I'll help carry down the microphone. Going back to Audrey, I think there's lots of evidence that many consumers use too short a time horizon when they're making important decisions, and economists generally agree with that. And then that's a rationale for why we expect our governments to use a low discount rate and a risk-free rate of interest. But isn't it true also that in our modern world, the governments are looking too short-sighted? They're worried about the next election rather than planning for 20 years from now.
Yes, that's the thing. I mean, we kind of say, okay, we understand the spaces where the market, it can't be left to individuals, and we need the public. And I gave the example of long-term care as one that's not surprising for where individuals don't fill in. It's a long view. You know, I'm not thinking about when I'm 90 and decrepit. I'm not thinking about what I'm going to need. It's uncertain, right? What is going to befall me and when? So it's not surprising that, you know, markets, complete markets in contingent securities may not emerge in that context. So it's a quintessential space where the public payer should be present and stepping in. And so this is the tension, is that why don't they? And you often get these political vagaries, and sometimes politicians are sneaky. They want to bring something in, it's going to be costly, but what they do is they say it's not going to apply to you people, it's going to apply to the people coming after you. And so they'll do that with, you know, right now a lot of systems are pay-as-you-go. So the young are paying for the old, and whenever you have a mismatch between the size of the young versus the old, we get into fiscal problems. And so really we should be pre-funding ourselves, right? But nobody wants to be told that they need to be paying now for when they're 90. So I think this is a path forward, which, you know, the political process has kind of put forward on its own, which is to impose, the current generation imposes the cost on the one coming behind them as a means to doing what's in the long run interest of society.
And a follow-up question on that. I think that you said some harsh words about our bureaucrats as not planning ahead far enough for instance, too many elderly who are going to fill up the hospitals, or not enough technology to accommodate demand, or generic drugs. These are examples where it looks like a government error that weren't planning very well. And I wonder if instead there were lots of bureaucrats who have forecasted the population aging and the new technologies, and the challenge is moving from the executive bureaucrats who can forecast these things to leadership in Congress or maybe executive branch of actually be willing to do something about it. Which do you think is true in Canada or the US?
I think another issue is that, you know, you're quite right. There's a lot of very effective, very bright people in the decision-making community, but they're confronted with a structure that's there, that is immovable, or at least changes very slowly. And so, for example, if we think about people being hospitalized, we got a number of structural barriers as to why people don't get discharged from hospital. One is that, you know, you discharge somebody, when they came in, they were high cost. As they got well, the cost per day went down. Now you get rid of them and you admit another person, boom, your costs go back up again. You know, so this doesn't seem like a bright thing to be doing, so you keep people in. Then you've got the issue of, we quite happily talk about home care in Canada and, you know, want people to age in place and stay at home. But the problem with that is that when you shift the site of care from hospitals to the community, the production process changes. So, you know, in a hospital floor, you have a nurse. That nurse can walk around a room and eyeball 4 patients. You change that, the same people with the same conditions, and you move them out to the community. You have now decreased the marginal productivity of the nurse. So it's exactly the same nurse, same skills. You've changed the setting. So the fixed cost of the hospital, it still needs to heat the place and light the place and keep the bed. That hasn't changed. But what you've done is increase the costs in terms of operations. So that also militates against moving care to the community. And I can go on, but the point is that that is what bureaucrats have to contend with. Any individual has to come up against the structure in which they're operating.
Great. And Mark, on a sort of related theme, if you want to pick up the mic, you talked about how because costs are growing faster than income, the government is now, I believe you said, public rationing has gotten stronger than it was. Is that inevitable? First, that's a little, strong. I mean, why don't we just keep increasing our spending on healthcare to keep up with it? Okay.
So, good question. Just to clarify what I meant to say, if I didn't say it this way, I mean, for many years prior to the fiscal crisis, we saw that. We observed that governments were spending, the increase in costs year to year was greater than the increase in economic growth. Right. So what I was giving you was just an equation in a sense that what has to happen to finance that, right, is either they have to borrow more, tax more, or take from some other pocket in government, right? We have seen something different since the financial crisis, which is a slowing down of spending at the public level, overall actually, but what concerns me is that it has happened at a greater level in the public sector than it has in the private sector. Meaning that although costs are slowing down, part of the way that the government is dealing with this cost control is to offset it onto the private sector, right? So that means that people are spending more out of their pocket or more on private insurance. So that's the point I was trying to make.
Sure.
And the implications, there are equity implications from such a switch, right? Because in almost every system where there's both public and private, the public system is more equitable in no matter how you measure it than the private part of the system, right? So you might say, well, that doesn't, you could approach this problem from an overall, can't we just reduce the amount of spending in healthcare without this kind of shift? And yeah, sure we could. I mean, it's feasible, right? And we have lots of areas where we know that we're spending too much relative to what we get back, right? Or that there's variation in the types of care where some care costs far more than other types without additional benefits. And one doesn't necessarily, in fact, it absolutely should not rule out the other. Right? We should definitely be pursuing those avenues where we can reduce cost without sacrificing quality, right? But also be conscious of the fact that to answer Audrey's question, is there a nimble system out there that can respond quickly to these? There isn't, right? And so the levers that governments do have tend to have more immediate equity effects than the longer term strategy of saying, okay, how are we actually going to reduce area variation, or how are we actually going to shift the kind of spending from potentially high cost to lower cost management of chronic. Those kinds of things have to happen too, but I think one needs to keep in mind as a public funder and as a voter that the more typical lever of just putting the brakes on actually has equity implications.
And a related question, I want to quote my good friend David Cutler, who may not have said it as directly, but David Cutler from Harvard, that, well, what's the problem with spending 25% of GDP on healthcare? After all, we're all getting more money. What are we supposed to spend it on? More cars, more computers, more housing, or maybe better health? What's wrong with spending more on better health?
Absolutely nothing, right? Absolutely nothing. In fact, when I say I have a problem with the word sustainability, it's for that reason, right? That we have to spend our money somewhere. Healthcare is not a bad place to do it if we're getting good value and people want it. The issue seems to be for most countries, not every country, but for most countries, it's not as much about how much we ourselves are spending on healthcare for ourselves, right? It tends to be more an issue of how much we're spending for healthcare for other people. Right, so it's the public costs. Am I prepared to pay more tax or greater premiums for other people's care? And that's where you get this backlash. I actually think it's much more a discussion about, how much do I want to insure other people who are different or less wealthy or less sick, more sick than me, and not, am I prepared to give up the big screen TV or something else for more health care for myself? I almost always am.
Okay. Agnès, very good. Interesting talk. You made some interesting discussion of how policymakers should place more attention to consumers' preference, and consumers should have more of a direct role in the healthcare system. I think words to those effect. I mean, maybe I'm slightly paraphrasing imprecisely, but here's the simple question. Isn't it true that the politicians that we elect are mostly going to reflect the political party that they come from? And isn't there a danger of them either flip-flopping or at least changing the direction of our healthcare system in response to swings between conservatives and liberals or Democrats and Republicans?
So I'm going to answer first by saying that I didn't mean to say that policymakers should actually give more choice to patients, to people. I was saying there has been a trend of trying to more explicit to involve, to incorporate the preferences of the health sector that pertain to health more explicitly in the policy, in the policy arena. One way of doing this is, of course, giving more voice, but I didn't really discuss this, but it's interesting to see that in some countries, it's still something that people do. So currently in Finland, there's a big reform ongoing whereby they're trying to incorporate, they're creating a new level of government, incorporating and at this new level of government, harmonizing and integrating the management of health and social care. But this is a huge reform, but a very big part of the platform, this is a coalition government. And one of the parties really want more choice. So it's really about giving freedom of choice. So all I was saying is, this is a response to the expectations of the public to be more involved, and it's still happening that some countries try to really put more emphasis on competition and giving choice to people. But that's really not what I was, referring to. And I was thinking more about the example of a policy maker, and I think this is another way of answering your question, which I met in, and I have to say this because I'm finally able to pronounce it, in Świętokrzyskie. So, so it's in Poland, and I met this man who was an elected representative of the local government, and the local governments are in charge of hospitals, and so I asked him, what do you think, sir, about this hospital? Would you take your mother there? And he said, not if she were dying. I mean, not even if she were going to die in the next half hour. And I said, well, would you ever consider closing it? Absolutely not, because people move, because people are happy to have a hospital in the vicinity. So I mean, this is just, even for policy maker who is supposed to be representing, the preferences, it's just incredibly complex. So yes, I mean, it's political parties, or it's also, and this goes back to what you were saying also, is, if you think about the fish, and you can go back also to the fisheries, there is the mercury, but there is also, what's going to happen to the next generation of fishermen, and all of this has to be taken into account. So it's nice to do in a model, but when it comes to real life, it gets much more complicated.
So, since you wouldn't agree with my paraphrase of saying that governments should pay more attention to patient preferences, then you must agree with that governments should not pay more attention to patient preferences. Anyway, okay, and Daniel, I've enjoyed your talk, and it actually builds on Jim's talk earlier, which we didn't ask many questions, so now I get to ask you as well. I think actually one of the real lessons of any effort at measuring willingness to pay and qualities is this huge variation in people's preferences about these kinds of issues. Some people love seeing the doctor and would like life-saving procedures until the moment they die, and other people hate seeing doctors and they really wish a non-intrusive kind of decision. So the question is, how do these models best capture heterogeneity in preferences, and what should that imply for government decision-making? Not everyone's the same. They may have very different preferences.
Yeah, so that's a pretty interesting question. So how should we capture the heterogeneity? Well, basically, willingness to pay per se already, if you take it in a modeling structure, it already captures the heterogeneity. So for example, if you have one individual, this is talking theoretical, so one individual is about to die, he's going to be willing to pay a lot of money to be able to save, or at least to reduce for one amount or an amount X of the probability, way much more than if an individual would be willing to pay to reduce that specific amount if he were not in so much danger. And this is what's called the dead anyway effect. But then again, should we also, willingness to pay depends a lot on income. So for individuals that are richer, they are actually willing to pay more. So that would translate into, should be we saving more richer individuals rather than poor, because they are going to, in some sense, profit better from life. And there was an interesting case in the States where the EPA actually tried to change the value of per statistical life for the persons who were older. So there's a very interesting relationship between value per statistical life and how it varies with age, and it's actually an inverted U. And this says that people who are older are willing to pay less for the lives, and hence, should we really take that into policy into account? So it was a pretty big, how do you say, issue. Yeah, thank you. In the States, and hence the EPA had to retract from using that.
Very nice, thank you. Well, I've had my fun. Now I'd like to invite members of the audience to ask questions of any of our panel members. Anyone want to go first?
Okay, well, thanks for that. I could ask you all questions, but I'm going to focus on Agnès. So I was interested in what you were saying, Agnès, about OECD countries and where they're using citizens' juries to address what we might call ethical issues. And I guess one thing economists generally do is look at values from the perspective of the individual, whereas you might think on ethical issues, or indeed any issue, if we value something from the perspective of being a member of society, we might view it differently than if we consider our own preferences. So we might want something different for society. So I wondered whether the OECD countries who have done these citizens' juries have taken kind of a perspective of me as a member of society as opposed to me as an individual.
If you'd like to take the mic and respond.
Well, I actually...
Please take the mic.
Oh, sorry. I actually haven't really looked at an evaluation. I mean, the processes, I mean, each country goes by it very differently. I mean, they would, you know, who they call upon to be part of these, whether these is actually, you know, people who are directly concerned by the problems, or patients' representatives, or patients' association, or whether you actually call lay people. And so each, you know, in each country will have its different, for each topic, the difference. It might involve experts, or it might involve philosophers, it might involve, so I can't really, you know, I haven't studied, frankly, the topic enough to be able to tell you, but I've seen variations in all of these dimensions, and it's really more on an ad hoc basis. I mean, I don't think that this process, to my knowledge, which is limited and, you know, irrational, I haven't seen really systematic procedures for doing this. So it's really more ad hoc. Whereas on the, you know, in the Conférence Nationale de Santé or things like that, you have more institutional and rules, and which are decided on how this is going to happen and who's going to be involved. But on these national consensus conferences, ou Conférence Nationale de comment ça s'appelle? Sorry, I'm having a, what was it called? The anyway, no process that no systematic way of doing this that I could identify. And I'm actually not answering your question, but for lack of ignorance. For ignorance, sorry.
Thank you. This is Laporte from Evidencebased. My question also a bit to Agnès, but the whole jury. I was just, the session is about like decision making, policy, public policy decision making, and ideally as researchers, I guess we would all like to see evidence-based decision making, even if it's boring to say. But so my question, starting with Agnès, because it's easy to pick up from her points, saying that okay, there's the new tendency to give more voice and choice to public. Does it make any sense if the public doesn't have any information to make choice or express their preferences? Because as a patient, or as a general public, your choices are very much defined by your doctor's choices. I mean, this goes to the literature on medical practice variation, but also talking about policy decision, like this Polish policymaker who cannot close the hospital, although he wouldn't send his own mother. He wouldn't send his own mother probably because he has some information that the general public doesn't have, knows the mortality rates in this hospital is 3 times higher than anywhere else, but the public doesn't have this information. So I'm just surprised that none of you mentioned the word information and access to information for the public and for the decision makers. I think if you want to improve the policy making in any level, it's important to provide information which is accessible to patients, otherwise patient choice and preferences will stay as just slogans, I think.
If anyone wants to comment on that statement, that's fine, but...
I guess I would not see it as an on-off switch. You know, it's not true that in all cases we have to integrate, because we have the issue that was very well described about how do we actually measure what people's preferences are. But once, if you get that sorted out, then the issue is how do you take those and integrate them? And where should they be integrated? And so there are places where it should be integrated, but I think we've all discussed sort of limits to that. And one interpretation is that people just don't have the information to be able to make decisions. And certainly acquiring information may be easier in some circumstances for the central planner. But, you know, the case of the hospital, maybe this planner lives in a different area. So if his mother gets sick, he has the option of sending her somewhere else. But the people in that community may know that the hospital is low quality, but the comparison is nothing. So I'm just postulating that as an alternative explanation as to why that hospital, you know, they would want to keep it open, because their alternative is nothing or a mediocre place that provides care. If you changed it up and said, we could give you an excellent hospital or close this crappy one, you might get a different answer.
Can I add, just add 2 cents on your question, more at the beginning of your question, which is related to evidence-based decision-making, which of course I am also in favor, and everyone I think is in favor of evidence-based decision-making. What I've observed, and I spent, before I moved to France, I spent 10 years running a policy school where we were training people to go and work in government, and is that there are very few decisions that are made in the absence of evidence for 2 reasons. One, most governments now insist that you have some evidence, but what's more concerning is which evidence they choose to use, right? That you can find evidence to support almost anything that you want to do, and if there's enough vested interest in one area or another, they will create the evidence required for the alternate decision, right? And so the issue for the policymaker is to justify to the decision maker which base of evidence is the right one to choose, even when, right? Put yourself in the shoes of a politician, right? You also, as a politician, want to make decisions based on evidence, and you are just looking for that piece of evidence that speaks to your values, right? Even if your values are not actually where the bulk of the evidence is, right? And that's a real challenge, right? Because people cling to evidence that speaks to their preconceived or deep beliefs, you know, their values on a decision, and so we get all kinds of evidence presented to ministers or politicians, congressmen. And the challenge is to have only the evidence we really believe to be credible make it there. And you'll often get the question back, when I worked in this field, right, show me the other side too. I want to see both sides, right? When often the evidence doesn't have another side that's credible, and yet you're asked to present both sides. So there's a real challenge that is hard to overcome, right? And the best we can do is prepare policymakers to find ways to present evidence with weight, right? Here's the evidence that is weighty, and here's the evidence that you're asking for because you want to see both sides. But this stuff doesn't have much weight. But that's actually hard to do.
So in answering, I guess I have to be careful where Randy is sitting, because he's going to distort my word and say I didn't think evidence matters. But no, I think, what you've seen when you actually provide evidence to, about the quality and the performance is that it doesn't necessarily have that much of an impact on how people make their own decision, whether they're going to go to this hospital or that hospital. It perhaps has often more an impact on how the providers measure themselves, and that might change their behavior more than actually, what people actually do when they start voting with their feet. So I do believe that information matters, and that it's gonna change change things. So on the, when it comes to actually involving the people in the decision making, like in many areas, there is contradictory evidence, but there's also a lack of evidence that it makes a difference to actually, consult the public. As in preparation for this, this afternoon, I was actually looking at, can we find evidence that it makes a difference, that consulting the public actually makes a decision in the outcome of the decision? And I'm not saying it doesn't. I'm just saying that, it has yet to be proven that it makes a difference. And the last thing I wanted to say was that, for instance, in NICE in the UK, they actually provide training to the people. So before they involve them in those, panels for deciding on the, deciding or participating in the decision-making process, they actually offer training to the citizens to actually arm them better to understand the evidence that is presented to them, etc. So that's one way of solving that problem.
Hi everyone, thank you for all your different speeches. It's very interesting. I'm Jean Guo, a researcher at Hospinnomics, and I guess this question follows up on Zeynep's and also kind of looks at our focus is more on the individual preferences to health and at what level are we able to integrate that. So following up on what Daniel talked about and trying to incorporate certain measures, and also on the question also posed earlier, how, I guess, from a researcher's perspective, we're very interested in capturing, the different groups and the different types of heterogeneity for evaluating a certain decision. So how do we ensure that certain different groups are taken care of when we evaluate that, and at what extent would we be ready, or if not, to kind of incorporate those decisions into governmental policies, per se, the OECD? Like, when would we be ready to kind of implement that?
Was that targeted at a particular person?
For Daniel or Agnès or anyone.
Daniel, you go. It's your chance.
So I'm trying to think about a good answer to that. So I guess let me give you one critical example on when the preferences for patients can really shape a lot the decisions, and that goes to a little bit for what Agnès has said. And it's, for example, in Colombia, we have a, so I'm Colombian, but those who don't know. So we had a system, or we had a system, I think that's changed right now, at which the patients could just go to the Constitutional Court and ask for a treatment that was not being provided publicly. And that treatment could cost a lot of money. And there you have your preferences, you have this individual that is identified, and that there you are going to have to treat that. But the person cannot finance the treatment, and hence goes to the Constitutional Court and changes the way the system works, literally. And that happens, and that used to happen quite a lot. So I don't know Colombia is now entering a process of getting to the OECD. I think that the change it's already happened. But then again, should we really want to finance that particular individual? Because if you finance that particular individual, you have to take into account as well that by providing the money to that treatment, then you're in some sense leaving out all the potential benefits that you could have got with that money. So you could have saved other individuals using that money, a lot of them maybe by introducing a new type of railroad or safety in the transport area, for example. So again, that's a really difficult question into what value should we use. Again, here, I think here in France, we are using one specific value, which is 3 million value per statistical life matter for the health transport. And again, it's only one specific value. So how would you actually try to accommodate that? You could do some sensitivity analysis in order to try to figure out that. But still, is it morally okay to put a different value for individuals or that are younger? Hence, should we value more kids? And that in general, we find that when you're valuing risk reductions for mortalities, usually you find that individuals are willing more to pay for cancer diseases and also for their kids than for their own. So yet again, I don't think that it's more a debate that has to go on the policy level on which values should we take. We as researchers, we can just say that those values differ.
As the moderator, I'm going to use this prerogative to ask one more question of the general panel. And it relates to an interest of mine on some current research. A typical scenario for deciding about a new technology is they find some population, let's say a group that has 100,000 people, and they find a new procedure that costs 10,000 euros and it's worth much more than 10,000 euros, and so it gets approved for treatment. And lo and behold, once this procedure is approved for treatment, instead of being done on the 100,000 people that it was appropriate for, is done on 10 million people because it's free or largely subsidized by insurance. So how do we reconcile these decisions made about when to use a procedure or not against the reality that the consumer pays very little for it and is happy to have the knee surgery or the special expensive drug used, even though really the value is low? And this again gets to heterogeneity in preferences or values. So any comments from the audience, from the panel?
Well, I'll take a crack at it. So, this raises the issue that, you do the RCT. RCT says, looks promising, this treatment, do the cost effectiveness, go to the public payer, convince them, get some fancy consulting firm to do a nice package, slips past the funder, gets funded for, as Randy described, this precise clinical group. And then it goes out and it diffuses, right? And for all the reasons, that he highlighted. So I think, you're starting to see countries like the UK and Canada and many others who are starting to do asking companies to do post-market evaluation. To say, you told us that this drug had all this promise or this treatment, prove it. Is it sustained over the long run? Is it sustained in the population that you defined it to be effective in? Are there groups in which it's actually doing harm? And if that's the case, you're going to have to reimburse us. And of course, there are implications of that. It's rather satisfying, to say, yes, let's punish them. But the implication is that, if I think about it sort of on the spot here, is that that will change the way RCTs are designed, right? To mitigate against this risk, to somehow identify the unobserved heterogeneity in that population, that these things for which the RCTs are currently not powered to detect. That's going to increase costs, I would suspect. And those costs will ultimately be passed on to the public. So, there's no free ride. I think it's still preferable to have more complex study design, right, than to subject people to unnecessary treatment. and sort of say, whoops, you know, sorry, right? We subjected you to this horrible thing. We want to prevent that. So that's sort of how I would see it unfolding.
Can I give you the academic answer instead of the practical answer? I mean, so my academic answer would be we shift from what we fund to what we treat, right? The problem is when you focus on what we're going to fund and then we apply it broadly, we end up with use and costs that are not appropriate, right? If instead we focus on this is the disease that we're going to treat, and we are going to be open to the most cost-effective way of treating this disease, right? It starts to shut the door down on just because this is the most cost-effective way to treat this disease, it doesn't mean that it is at all applicable if it's not this disease, right? And it's an academic answer because that's not easy to do, although I think actually if there's a country that's starting to lead the way here, it's the US, right? More than others, which is good to see.
This is not a way to close a panel because we could start a whole conversation just on this.
Oh, well.
Oh, well, we'll have a... But, I mean, I think there's so many ways to answer this question and bring arguments and counter-arguments because, you know, when you do clinical trial, you do them on specific populations, and then you might find that it actually makes sense to, and it can be less expensive to prescribe off-label, you know, for the populations for which this hasn't been approved. And it might actually save you money. I mean, sometimes it might because, you know, the drug that is approved for that cancer, then for this one, it's actually not approved, but it's actually quite effective. And so it goes to, you know, how do we collect the real-world evidence to show this and change the processes that actually allow for this to happen or not. I mean, it's just incredibly complex. But so I want to not move away from the drugs issue because I'm not an expert, but I think I just want to say about, you know, how do we try to avoid these procedures that add no value? And I think there's something quite interesting here is really this movement called choosing wisely, but it's also called slow medicine in Italy, where you actually try to think, you know, about the actual benefits for the patients, and you really try to also educate the providers and not educate them because it's actually, this is mainly driven by physicians themselves who want to say, wait, you know, we're going to tell our patients that no, you know, the knee replacement for them, it's just not good. They might ask for it, but we're going to try to convince them that this low-value care should not be provided. But this is really shifting things and how to build. This is kind of a grassroots initiative which has been, you know, started in many countries, and for the governments, then the question is, you know, how do we actually try to build on this and make this more systematic? But there is also the issue of you just delist, but then, you know, it may not work. I mean, if you do the C-section, sometimes it's useful, you know, to have a C-sections, but in many cases it's not. So you have opened 2 new topics.
That's all right. As Oprah would say, you have a few seconds left. Please give me.
So maybe I'm wondering about what the question that Agnès just said is, how do we eliminate those procedures that are not worth it? So, and I'm wondering from my academic perspective, whether we should be using an element such as cost-effectiveness analysis to analyze that type of decisions. Because at the end, cost-effectiveness analysis doesn't really gives us whether we should be using that specific intervention or not, per se.
Thank you very much. Please thank my panel, and we'll see you at the break.